Namaskar and hi to all the viewers. A very warm welcome to today's special edition of Critical Care Webinars. And today is our International Faculty Webinar. It is indeed a pleasure and honor to welcome Dr. Aranya Bagchi to the webinar, who will be taking this lecture. So Dr. Bagchi is actually trained initially in India. He did his medical school and PGI Chandigarh Anesthesia Regency. Now he's at Massachusetts General Hospital. So he's assistant anesthetist in the Department of Anesthesia, Critical Care and Pain Medicine, Massachusetts General Hospital. He's assistant professor of anesthesia at Harvard Medical School, and he's a clinician investigator, NS Critical Care DM Medical PMO, Mass General Research Institute. So it's a great pleasure and honor to welcome you, sir, to our forum, our critical care webinars, and it will be great to hear from you. Thank you so much, and I welcome the audience.
Thank you very much, Dr. Bansal. It's a pleasure to be able to speak at this forum. So I'll get started. Like Dr. Bansal said, I'm an Indian by birth. I trained in India for medical school and residency. For the last 9 years, my practice has been exclusively in cardiovascular critical care. And a lot of what I'm going to speak about today is derived directly from our day-to-day experience in the ICUs. I do some research as well. None of my research interests are relevant to this talk. So pressure waveforms in critically ill patients, intensivists make a living by interpreting pressure waveforms. They include arterial waveforms, PA catheter-based waveforms, intra-aortic balloon pumps, impellers, ECMOs, all of these, right? Talking about every single possible pressure waveform in critical illness would take days. So today I'm actually going to focus on one of the most basic waveforms, the CVP. I'll also talk about measuring right ventricular pressures, which I do a lot in my practice. And what I'm hoping to do is to discuss waveforms, CVPs, and RV pressure specifically today, talk about concepts, talk about practical points, and where relevant, provide some evidence for the points I'm making. Since the late 90s, early 2000s, central venous pressure monitoring has been very much looked down upon. And there are a number of reasons for that. I will address those reasons and try to convince you that there is a ton of information available in CVP tracings and that we should be measuring and looking at our CVP waveforms in our critically ill patients. So we'll talk about what the arguments against measuring CVPs are, understanding the morphology, not just the CVP is not a number, it's a waveform, and understanding that waveform is really key to making use of the CVP. And although essentially all the literature in critically ill patients and CVP monitoring focuses on fluid responsiveness, there's a lot of other information that the CVP provides, specifically related to RV function, related to decongestion, and even less commonly appreciated, the CVP can work as a poor man's esophageal manometer, right? And then a couple of practical points on troubleshooting CVP waveforms, because we've found that, especially if you're using a PA catheter, the CVP is often misread because of technical reasons. And then I will touch on, somewhat more briefly, right ventricular pressure monitoring, which requires a PA catheter, and why right ventricular pressure monitoring adds to the management of our critically ill patients. One caveat to all of this is that a lot of this data and a lot of what I'm going to talk about is very, very relevant in patients with cardiac disease, right? Whether they're in a cardiac ICU or not. If you have RV dysfunction, if you have severe LV dysfunction, this information is important. If you're in a non-cardiac ICU taking care of sepsis, ARDS in a patient with a normal heart, some of this is still relevant, but it's not as relevant as it is if your heart is bad, right? All right, so we'll start with defending the use of CVP measurements in critical care. So in the 2000s, papers like this were very common. I'm just going to read out what I highlighted. Based on the results of our systematic review, we believe that the CVP should no longer be routinely measured in the ICU, operating room, or emergency department. Another review, and this is in the British Journal of Anesthesia, says that clinicians seem compelled to give fluid when the CVP is less than 8 millimeters of mercury. The only solution to this pervasive problem is to stop measuring the CVP. I give lectures at a number of hospitals around the US, and at least in the US, I don't know what it's like in India now, but in the US, most ICU patients have central lines. They actually the CVPs aren't being transduced. And a big part of the reason is articles like this where people have become convinced that the CVP is a waste of time. And I'm going to try to argue that it's not. But before we do that, it's important to see why the CVP developed such a bad reputation, right? The claims against the utility of CVPs in critically ill patients are, one, that it doesn't correlate with blood volume. Second, it's a poor index of volume responsiveness. Third, there is no evidence that the use of central venous or pulmonary arterial catheters improves outcomes. And all of these claims are correct, right? None of them are wrong. But let's look at them in a little more detail. Right? So this is a classic paper that came out in Critical Care Medicine in 1984, where they used tagged red blood cells and looked at the changes in blood volume and correlated that with the CVP. And as you can see, it's a scatter plot, right? There is no CVP value that is correlated with a greater or smaller change in blood volumes. The problem is you shouldn't expect the CVP to correlate with blood volumes. It's extremely aphysiologic to think that the CVP correlates with blood volume. And the reason is that the CVP is proportional to the stressed blood volume, not the total blood volume. Most of you know that the venous system has a huge capacitance, and it takes a fair amount of blood to produce a transmural pressure at all, right? So the amount of blood that begins to produce a transmural pressure is called the unstressed blood volume. And everything above that is called the stress blood volume. A very simple analogy for that is the analogy of a tub with a spigot somewhere in the middle, right? Any level of water below the spigot does not produce any flow of water in the spigot. And therefore, if this is your CVP, it doesn't matter how big the tub is below the spigot, the CVP here is going to be zero. The CVP is only proportional to the amount of water, in this case, that's above the spigot, which is, in this analogy, representative of the stressed blood volume. And again, as you know, the stressed blood volume is variable. Sympathetic tone, vasoactive medications, all of these can affect the venous tone and change the amount of stressed blood volume. So the CVP should not be thought of as being proportional to the blood volume, because it's not. It's not proportional to the total blood volume, right? And then why do you care about blood volume? Nobody says we need to resuscitate our patients to some magical blood volume number. We care about perfusion. We care about venous pressures, because venous pressures are more important than venous volumes in determining organ perfusion. To take the analogy of cerebral perfusion pressure, right, which is MAP minus ICP or MAP minus CVP, whichever is higher, perfusion pressure for organs such as the kidney and liver is the MAP minus CVP. So the venous pressure itself is an important metric, and we'll come back to this when I talk about decongestion. The next charge against the CVP is that it's a poor index of volume responsiveness, and that is correct. However, again, to expect the CVP by itself to predict volume responsiveness is a gross oversimplification. What this figure shows is one of Guyton's original reviews, where he combines his insight, as some of you know, was to combine the cardiac function curve or the Starling curve with the venous return curve, right? And where the cardiac function curve and the venous return curve intersect, that is the CVP for a given situation, right? So as I'm quoting from Guyton's paper here, the right atrial pressure is not one of the primary determinants of cardiac output, but instead is itself determined simultaneously along the cardiac output. So in other words, the CVP is a complex metric, right? And we'll come back to that in a second. But if you look at this graph, or if you think about the Guytonian approach to venous return and cardiac function, it's obvious that the CVP as a number is not going to be sufficient information to predict fluid responsiveness. So it is correct that the CVP is not very good at predicting fluid responsiveness, although there are ways to use it intelligently to do that as well. But that's not the primary purpose of looking at the CVP. All right, so if it's not the best way to look at fluid responsiveness, can you use it at all? And I'd argue you can if you couple the CVP with a measure of cardiac output. If you know your CVP and you know your cardiac output, give a fluid challenge and you see the effect of that fluid on the metric of cardiac output. Now, that metric of cardiac output could be a PA catheter, it could be a non-invasive monitor, it could be echo. It could even be the central venous saturation, right? If you give a quick fluid challenge, assuming hemoglobin concentration, arterial saturation of oxygen, and oxygen consumption do not change, the central venous saturation is proportional to the cardiac output. So can you use the CVP to predict or to test volume responsiveness rather? Yes. Is it the best metric? No. But that is not a reason to discard CVP measurements altogether. Another use of the CVP when you're giving volume, right, is to define the adequacy of a fluid challenge. So these two figures show on the left side a fluid responsive patient, where by giving volume, what you're doing is you're increasing the mean systemic pressure, assuming venous resistance does not change. And if you're on the ascending portion of the Starling curve, that increase in venous mean systemic pressure will produce an increase in stroke volume. If you're on the flat portion of the Starling curve, however, the same change in mean systemic pressure is not going to produce an increase in cardiac output. There's also some data and mostly expert opinion, but it's a practically useful point that if your CVP goes up by 3 to 5 millimeters of mercury after you've given a fluid challenge and it stays up for a few minutes, that is telling you that your RV is probably, the capacitance of your RV is not high enough to accept that fluid challenge. In those cases, you should not give more fluid. And the last argument against using CVPs and PA catheters is that these catheters or these measurements have never been shown to improve outcome. That's true. I would argue that a monitor should not be expected to improve outcomes. This is controversial. There are a lot of people who believe that a monitor should show an improvement in outcomes. I would argue that if a monitor, especially as complicated as a CVP or a PA catheter, which provides multiple data points, and when management of a patient based on these data points becomes very variable, it is very, very difficult to link a monitor to better outcomes. Now, you can show that a monitor hurts patients because the damage or the harm caused by a monitor generally shows up in a study. And all the big PA catheter randomized controlled studies do not show harm as long as you exclude transient arrhythmias, right? In patients without, like I said in the beginning, in patients without cardiac dysfunction, sepsis, ARDS, you'll be fine without a PA catheter or a central line. I would argue there's some other piece of information that the central line will give you, and we'll look at that in a second. But you can take care of your patients very well without a PA catheter or central line. In patients with severe cardiac dysfunction, I would suggest that these metrics are essential. All right, so how do we get most out of the CVP? One of the problems with the CVP is, and this is also exactly applicable to the pulmonary capillary wedge pressure, is that these pressures are actually two pressures. We commonly talk about filling pressures, right? And what we mean is the RV end diastolic pressure, or the preload. The preload is a pressure, incidentally. It's not a volume. So this shows a tracing of a normal CVP with the ACV and positive peaks in the X and Y descents. The RVEDP is the end diastolic pressure. And the end diastolic point is the end of the A wave, right? So that's your RVEDP. But it's also, the CVP also incorporates the back pressure, right? The pressure that against, when the heart is contracting, there's a pressure that's left behind. And the less effective the heart, the higher that pressure is, right? And so that back pressure is also reflected in the CVP. In a normal patient, and that's basically the area under the curve, the mean area under the curve of the CVP. In a normal patient, or a patient with a normal heart, these two are pretty equal, right? So the RVDP and the mean right atrial pressure are the same, and that makes it relatively straightforward. But in many patients, and I've drawn an example of a patient with severe tricuspid regurgitation. So you have the A wave, you have the CV regurgitant wave, and the sharp Y descent. Here you can see that the RVDP is very different from the mean right atrial pressure. And you'll hear cardiologists, or at least, cardiologists here will all the time say, oh, this patient's got TR, don't worry about the TR. That's actually not correct. You don't worry about the TR in the sense that the TR doesn't reflect your RV preload, because the RV preload is still here, but a significant TR does cause systemic venous congestion exactly the same way as significant mitral regurgitation causes pulmonary edema, right? So in patients with complex CVP waveforms, the mean right atrial pressure has to be taken into account in addition to the RV end diastolic pressure. And this is one example, but CVP morphology is really important. Again, a CVP number in and of itself makes very little difference or very little sense in managing your patient. So this figure here shows a relatively normal CVP wave on top, ACV, XY descents. The second panel shows a patient with a sharp X descent. The third panel shows a patient with a sharp Y descent. And I'll come back and I'll talk about the Y descent in some detail. This example here, the CVP is superimposed with a PA tracing. You can see this patient has tricuspid regurgitation, and you can see as the RV is ejecting blood into the pulmonary circulation, there's also reflux of blood back into the right atrium, giving you the CV waveform, and then there's the Y descent. And these are other examples of patients with tricuspid regurg. And you can see here that the RVDP, which is the end of the A wave that I'm pointing out with the cursor, is actually significantly lower than the mean right atrial pressure, even more so in the lower tracing. And these tracings are all tracings from my patients in our ICU. So you've seen what a sharp Y descent looks like. Why is that important? Sharp Y descent can be caused by many things: constrictive pericarditis, restrictive cardiomyopathy, severe TR. Very importantly, it's very, very common post-cardiac surgery and post-heart transplant, when the fresh heart is, it's just spent a lot of time ex vivo. It's gone through the shock of harvesting, ex vivo perfusion, and bypass. These RVs are very, very often, the CVPs in these patients have a sharp Y descent. And what this means that these RVs are diastolically incompetent. They are very stiff RVs. There's a lot of data on LV diastology, which we predominantly measure by echocardiogram. RV diastology by echo is a very, very nascent field. There's no real guidelines for RV diastology. The CVP basically tells you about RV diastology. Patients with a sharp Y descent have stiff right ventricles. What does that mean? That a couple of very, very important practical points, right? One is that they have limited preload reserve. Why is that? Because what a sharp Y descent means is that as soon as your tricuspid valve opens, the Y descent, as you know, is the tricuspid valve opening, the first rapid filling phase of diastole. When the tricuspid valve opens, blood rushes into the right ventricle, and that sharp Y descent shows a rapid increase in pressure as blood fills the right ventricle, right? What that means is that right ventricle cannot accommodate a lot of volume. And so the technical term for that is limited preload reserve. What that means in practice is giving that patient a bunch of volume may not be helpful. The second important significance is that these patients tend to be rate dependent. Why? Because their stroke volume is relatively fixed, right? A stiff ventricle cannot accommodate stroke volume. So yes, people say with diastolic dysfunction, you need to give them longer filling times. That's only for mild diastolic dysfunction. With significant diastolic dysfunction, and especially severe RV diastolic dysfunction, if you're giving them more filling time, you're just giving them less cardiac output because their stroke volume is not going to increase with filling time. So you need to avoid bradycardia. And if you have pacemakers available, so post-cardiac surgery epicardial pacemakers, or the patient happens to have a permanent pacemaker implanted, one very useful way to improve their cardiac output and improve perfusion is to increase their heart rate. And thirdly, they depend on their atrial kick. If patients with a stiff right ventricle lose their atrial kick, their hemodynamics get even worse. So that means if they go into atrial fibrillation, rhythm control rather than rate control should be the primary aim. And there's actually a decent amount of data going back decades. A deep Y descent, so that's shown here on the in panel A. This is, again, you'll recognize this pattern from the patterns that I showed you. Deep Y descent is associated with a higher incidence of cardiogenic shock and a higher incidence of mortality in patients with right ventricular myocardial infarction. Much more recently, there's been a number of studies in the last 5 to 6 years on the importance of CVP morphology or JVP morphology in multiple settings. This is a relatively recent study that shows that if you have a deep Y descent in patients with heart failure with preserved ejection fraction, which is on the left side, your adverse cardiovascular outcomes rate, which includes sudden cardiac death, cardiovascular mortality, or readmission with heart failure, is substantially worse. So what this graph shows is Kaplan-Meier curves with low RVSP and distensible right ventricle, high RVSP with a distensible right ventricle, and then low RVSP and higher RVSP with non-distensible right ventricles. And you can see here that if you've got a combination of a high RVSP with a non-distensible right ventricle, your adverse event rate is much, much higher. Similarly, after you get a durable LVAD, as you know, there's an incidence of 30 to 40% of RV dysfunction after you get a durable LVAD. And again, the less distensible RV morphology defined by a steep Y descent. In this study, they defined it as Y descent greater than X descent, right? If you have a high CVP and stiff RV, a sharp Y descent, you've got 100% in their study, 100% incidence of RV dysfunction. Similarly, if your PAPI is less than 2, the PA pulsatility index, and you've got a non-distensible RV, you've got 100% incidence of RV dysfunction. So all of this tells you that, again, the CVP is not just a number. The morphology of the CVP is really important. And then there are a couple of other ways the CVP helps. So one way that you see CVPs being dynamic in an ICU is with rhythm changes. So you see a normal CVP here. This patient was being atrially paced. We stopped apacing. The patient has an underlying junctional rhythm, and you see AV dissociation here. This patient is being AV sequentially paced, but you can see the CVP tracing goes from relatively normal to AV dissociation to relatively normal. And that's because this patient has an underlying atrial rhythm, which is not effectively captured and taken over by the atrial pacemaker lead, which is quite common, right? Similarly, again, this patient goes from a sinus rhythm to a junctional rhythm, and you see Canon A waves. Right? Sometimes it's actually, and if you look at the ECG here, the P waves are not super prominent in the ECG itself, but the CVP tracings are very prominent, right? So sometimes it's actually easier to identify an arrhythmia looking at the CVP than at the ECG. It sounds weird. If you're using PA catheters, the CVP port may be malpositioned, and it can sometimes give you erroneous values. And one clue to that is the lack of a waveform. In many patients, especially the PA catheters at around 46, 47 centimeters at the introducer, the CVP tip is very close to the introducer. And what you're seeing here is when you're pushing fluid boluses through the side ports of the introducer, you're changing the pressure in the venous waveform. This patient actually had a CVP of 2, not a CVP of 11, right? So you have to be very careful that you're measuring the right waveform. Another common place where the CVP can be misleading is post-heart transplant, where the CVP port in a PA catheter may be above the cavo-atrial anastomosis. And this patient was getting diuresed for about 18 hours because everybody thought their CVP was 20. And if you see their PA pressures, this looks like profoundly bad RV dysfunction. But their actual CVP is closer to 8 to 9. And again, you can see how the waveform, the lack of a waveform should always make you suspicious about the validity of the CVP tracing. All right, I'll quickly go over this. If you've got a PA catheter and you're transducing CVPs through that, especially if your patient is short, it's quite likely that your PA catheter is not advanced far enough. So if it's less than 47 centimeters, depending on your type of introducer, we commonly use a MAC introducer and a PSI introducer. It's quite likely that the port is very close to the introducer tip. So you can advance it if the patient, you're not wedged already when you inflate the balloon, or you can check the RV port. And I'll talk about RV pressures in this last part of my talk. All right, what other information can the CVP provide? Well, we've already talked about some aspects of RV dysfunction, especially RV diastology. I'll touch on it a little bit more, but the RV diastology piece itself, I would argue, is worth the price of admission to use CVPs. The most important utility of the CVP is as a guide to systemic decongestion. I'll talk about that in more detail. And I'll touch on the use of CVP as a measure of work of breathing and transpulmonary pressures. So we know, as I said before, that venous pressures are really important. Venous volumes, less so. In septic shock, in cardiogenic shock, the strongest risk factor for developing acute kidney injury is a high CVP, right? So when you have a high CVP, that is giving especially in organs like the kidney, which are bound by tight fascial planes like the Gerotis fascia, what it's doing is you're compressing, you're sort of causing congestion, engorgement, venous engorgement of the kidney. And for a given mean arterial pressure, you're reducing kidney perfusion, right? This is one of the mechanisms of cardiorenal injury. And this whole concept of CVP targets, which is also one of the reasons why people turned against the CVP, right? It makes no sense to say that my CVP target is 8 to 12 millimeters of mercury or whatever. This was started out with the Rivers trial back in 2000. There is no physiologic basis for doing that, right? The ideal CVP is the lowest CVP that you can get that is compatible with adequate perfusion. This is an example of a retrospective study that looked at patients with septic shock. And you can see this is the risk of AKI, and this is the CVP. And you can see that it's almost linearly proportional to the CVP. The higher the CVP, the higher your risk for AKI. This is a relatively recent study from 2022 that looked at a retrospective cohort of a large retrospective cohort of patients with many kinds of critical illness, and they looked at the relationship between the CVP and the odds ratio of developing kidney injury. And you can see in almost every single case, this is CSRU cardiac surgery, post-cardiac surgery patients. But whether it's heart failure, post-cardiac surgery, sepsis, the higher your CVP, the higher your risk of kidney injury. So this is really important. Yes, the CVP is not a great metric of volume responsiveness. It is, however, a really, really good metric of congestion. And provided you've measured it appropriately, it gives you very actionable information. Now, is the CVP your only way of identifying this? No. POCUS is really useful here, and the protocol called VEXUS, venous excess by ultrasound, which I use routinely in my practice, is also a very useful adjunct to the CVP, especially when your CVPs are sort of in the mid-range, say they're between 12 and 15. If your VEXUS scan shows congestion, you should decongest. On the left side, you can look for bilateral B lines, or you can look at the left atrial pressure using the E by E prime ratio to identify left-sided congestion. We're not talking about ultrasound today, so I'm not going to go into details of that. So, you've got a patient on epi, dobutamine, norepinephrine, vasopressin. Should you diurese this patient? And the answer is yes. If your CVP is greater than 15, and if that CVP represents a significant increase over the patient's baseline, then you should diurese. It doesn't matter if the patient is on presses. Now, there are exceptions. If you take care of patients with post-Fontan physiology, for example, they have an obligately high CVP. Their CVPs are typically above 25 millimeters of mercury because their pulmonary vascular flow is completely passive, right? The gradient is between the CVP and the left atrial pressure. And then if you have some patients with severe chronic right heart failure, their normal CVP may be different from what we consider normal. So patient context is always important, but in a patient who has a relatively normal right heart, if the CVP is high, it is completely fine to diurese them, even if they're on presses. This is getting more acceptance in the general critical care community. If some of you will be familiar with the FACT trial, the fluid and catheter treatment trial back in 2006 for ARDS, they would start diuresis 12 hours after the patient coming off presses, right? I would not support that kind of a strategy. If your CVP is high, that suggests the need for decongestion. That patient should be diuresed. And then patients with, the CVP is one of the most useful metrics for RV function, aside from the reasons we've talked about. And that's because if you look at patients with pulmonary hypertension, right? So that's a very high risk patient population. They come for elective surgeries, emergency surgeries. They're in the ICU. They tend to have really bad outcomes. And people often get very fixated on the PA numbers. But as you can see, over time, in patients with pulmonary hypertension, the pulmonary vascular resistance continues to increase. But because at some point the cardiac output starts to drop, this is when the patients are decompensating, right? Your PA pressures start to drop as well. So your PA pressures in and of themselves are actually one of the few things that are not prognostic in patients with pulmonary hypertension, although it sounds weird, or they're among the least prognostic factors. The point where your CVP starts to rise, that's a really, really dangerous time for your patient. So for example, if you have a patient with a PA pressure of 85 over 26 and a CVP of 6, compared to another patient who's got a PA pressure of 34 over 22 with a CVP of 16, I would be much, much more worried about the latter patient, right, than the former patient. A high CVP with a low PA pressure is a sign of a bad right ventricle. So if you had to choose a single monitor, right, that's sort of an artificial question, but if you had to choose a single monitor for RV dysfunction, I would recommend choosing the CVP. All right, I'll touch upon this because this is something I do in my practice, and there's a decent amount of data for this, but it's not commonly used, right? The CVP is intrathoracic, assuming you're putting in CVP through the IJ of subclavians. This is not true for the femoral CVPs, obviously. CVPs are intrathoracic, so when a patient is breathing spontaneously, say on pressure support or something, the change in CVP, so the delta CVP that you see here, is very proportional to the delta pleural pressure, right? Because your CVP is here, your pleural pressures, this is what you care about for the pleural pressure, you'd be measuring your esophageal pressures here. And there's a lot of data going back to the 70s that the delta CVP is very, very well correlated with the delta pleural pressures, not the absolute numbers, the deltas. So what does that mean? That means two things. One is a high delta CVP is a patient who's got a high workup breathing. This is quite well established. The second is that you can estimate your patient's transpulmonary pressures when you're giving them a trial of pressure support or pressure control, because as you know, transpulmonary pressures are airway pressures minus the pleural pressures. So if you've got, for the sake of argument, you've got a delta of 10 millimeters of mercury, that's about 13 centimeters of water. And if you're ventilating that patient with a pressure support of 15, the transpulmonary pressures are like 15 plus 13. So that's 28 centimeters of water, right? In this example, I've used 10 plus 13. So that's 23 centimeters of water. But either way, those transpulmonary pressures are very, very close to the kind of pressures that continuously injure lungs. So if your patient's recovering, recovering from ARDS, and you're seeing this kind of a pattern, you might want to take a step back and determine whether or not it would be safer to return this patient to more lung protective ventilation. Now, obviously, if the patient's lungs are fine and they say this is a post-op patient, it's much less relevant. It matters, of course, where you measure the pressure, right? So this figure shows a combination of the CVP, PA pressures, and RV pressures. The RV pressures in the white, CVPs are in blue, and the PA pressures are in yellow, right? We know that we want to measure our CVPs, our PA pressures, or any intrathoracic pressure at end expiration, where the pleural pressure has the least impact on the CVP. So if this was a patient who was being passively ventilated, the lower the nadirs of the pressures is what you would record. If this was a patient who's spontaneously breathing, the higher pressures are what would correspond to end expiration. And as you can see, that's a big difference, right? So it's not trivial to where you measure your CVPs during passive or spontaneous respiration. The one thing to remember is if patients are on pressure support or if they're actively exhaling, so for example, if you've got bronchospasm, COPD, asthma, whatever, then your CVPs are going to be, and PA pressures are going to be suboptimal no matter where you read them, because your pleural pressure is always influencing the CVP. The other things, level the transducers. I measure my patient's CVPs and PA pressures a couple of times a day, and I always put the transducer at the sort of appropriate place close to the mid-axillary line, 5 centimeters below the sternal angle of Lewis, whatever you want to use, when I measure my CVPs, because patients move around, right? They're in bed, they're sliding up, they're moving around. No fixed transducer level is always going to be accurate. And a 5 millimeter difference in your mean arterial pressure may not be a big deal, but a 5 millimeter difference in your CVP is a huge deal, right? A lot of people believe that femoral CVPs are inaccurate. That is not true. Femoral CVPs are not only correlate, they agree to within 0.5 millimeter of mercury of your IJ and subclavian CVPs, provided intra-abdominal pressure is normal. If you've got abdominal compartment syndrome, are severely obese, or have IVC pathology like IVC thrombus or something, obviously femoral pressures are not accurate, but otherwise there is nothing wrong with transducing femoral CVPs. All right, so summarizing so far, the CVP can be used to determine the volume responsiveness of a patient if it's coupled with an index of cardiac output. It can be used to determine the adequacy of a fluid challenge. That's much easier to do. The morphology of the CVP, as I hope I've convinced you, provides really important information. The CVP is very, very important in identifying systemic congestion, and that hypotension is not a contraindication to diuresis. And the CVP is more relevant than the PA pressures in most cases, not necessarily in all cases, but in most cases, in identifying patients at high risk for decompensation. And finally, CVP changes with respiration reflect pleural pressure changes, and so you can use them as a rough approximation of an esophageal manometer. Goes without saying that you should be very careful when you make CVP measurements because of all the reasons we talked about a few minutes ago. All right, so now we'll move for the last 5 minutes or so to RV pressure monitoring. RV pressure monitoring is less commonly done across the board. To my knowledge, this was popularized by the group at the Montreal Heart Institute led by Andre Deneau among anesthesiologists and intensivists. Obviously, RV pressures are measured in the cath lab, but it's relatively uncommon to measure them in the ICU. But it's something that I found very useful. Why monitor them? Well, it's one way to sanity check your CVP. If your RVDP is as high as the CVP, then you know that your CVP is a problem. Another unusual instance, which I actually came across about a week ago, is if you have a high RA pressure and a normal RVDP, think of right atrial compression. This patient had a localized tamponade compressing her right atrium. But because the RVDP was normal and we couldn't see the right atrium well on transthoracic echo, it took us about half an hour, 40 minutes to realize that this patient was actually in tamponade. It helps identify RV diastolic dysfunction. There's something called RV limitation that I won't go into today. Can help assess RV systolic function qualitatively because the slope of your RV upstroke is proportional to the dPdt, the change in pressure with change in time. And very useful, though not very frequent, you can identify mechanical or dynamic RV outflow tract obstruction. All right, so how do you monitor it? So the PA catheters we use most commonly they're called VIP Plus. They have an additional RV port. The RV port is 19 centimeters from the tip of the PA catheter. The CVP port is 29 centimeters from the tip of the catheter. So you want to make sure that the RV port, in most patients, if you just put the PA catheter in, don't wedge it, the tip is in the main PA, and then you transduce the RV pressure, you'll find that the RV pressure is more often than not in the RA. Right? That's because the 19 centimeter mark is still sitting in the right atrium. So advance the PA catheter while for the wedge with the RV port transduce, and you will recognize when the RV is entered. So again, the white is the RV tracing, the blue is the CVP tracing, yellow is the PA line tracing. So the two ways to identify RV diastolic dysfunction, and the key place to pay attention to is the diastolic slope of the RV tracing. So you can see here, these are RV tracings of one of my patients. You can see that the early diastolic period begins here, the end of systole, until the end diastole, and there's very little pressure change. Some authors will say if there's a more than 4 millimeter pressure difference between the early diastolic pressure and the end diastolic pressure, you've got some RV diastolic dysfunction. There's some controversy about that, but this waveform, this is your square root. This is very, very indicative of significant RV diastolic dysfunction, as this paper also shows. And the important thing is that this descent is predicted or reflected by the sharp Y descent in the CVP. So again, you see this is a normal CVP, that's a normal RV tracing. These are cath lab tracings. This is a sharp Y descent, and you see the square root here. So these CVP tracings, for example, this patient actually had a CVP of 38. These CVPs would correspond to a sharp Y descent. And you can use that sharp Y. It's very difficult to fix diastology. Diastology is very important physiologically, but it's a little bit frustrating for clinicians because you can't improve diastology. You can't make a ventricle more lusiotropic, or it's not easy to, right? But you can decongest it, right? By diuresing this patient with these square roots, you can see how the degree of diastolic dysfunction was attenuated. Right? So that's one of the important things of following these kind of tracings and acting on them. They're not just academic, pretty tracings to look at. Now, the right ventricular outflow tract obstruction can be mechanical. So what is right ventricular outflow tract obstruction? It's when the RV systolic pressure is significantly higher than the PA systolic pressure. The definition of severe RVOTO is a 25 millimeter gradient, and moderate is more than 6 millimeters, right? So this patient was a post-heart transplant. You can see that they have a balloon pump in there. And the patient was bleeding, so their chest was packed. And you can see that there are, first, notice how high their CVP is. Doesn't have a good waveform, but you can see that the RV systolic pressure is 44, but the PA systolic pressure is only 18 millimeters of mercury. And this was because the packing material was compressing the RVOT. So when the surgeons did a washout, they removed the packing material and the patient got much better. Dynamic RVOTO is less common, but it's also really important for us to identify because these patients clinically behave like they have RV dysfunction. They tend to have high CVPs. They're on a lot of inotropes, but what's happening here, and so this is an example from one of our ICU patients, you can see that the RV pressures are way higher than the PA pressures because this patient got intratracheal milrinone in the operating room and then came up to the ICU because they were being treated for RV dysfunction. And they exacerbated that. The mechanism of dynamic RVOT obstruction is exactly the same as dynamic LVOT obstruction, right? Relatively low fluid, sort of hypovolemic patients who are getting high amounts of inotropes. And you treat them the same way you would for LVOT. You give them volume, you reduce the inotropes, and you see about in a couple of hours, the gradient has disappeared. The most extreme form of this can be seen in some patients after lung transplants, in whom their RV has been used to seeing very high pulmonary vascular resistances, and now you've given them a new set of lungs with normal pulmonary vascular resistances. And this is sometimes called a suicide right ventricle. You can see here the RVOT, the RV pressures are 108 millimeters of mercury with a PA pressure of 38. That's a 70 millimeter mercury gradient. These patients can be really challenging to manage. In this case, we were able to bring the gradient down to about, I think, 30 to 40 millimeters by taking off nitric oxide, taking off inotropes, putting them on phenylephrine and vasopressin and giving them volume. But the gradient didn't completely go away. All right, so we are about done. So I'll say for RV pressures, you can use VIP plus PA catheters or AV base port catheters. You should ensure that the RV port is in the RV. You can use them to confirm central venous pressures. You can identify diastolic dysfunction, RV outflow tract obstruction, both mechanical and dynamic. And the last thing I'll say is hopefully all of this has convinced you to pay close attention to the CVPs on your critically ill patients, especially if they have RV disease or if their cardiac function is poor in general. I will stop here and I am happy to take questions.
Thank you, Dr. Bagchi, sir, for a wonderful talk on waveforms, especially the central venous pressure waveforms, and so many illustrations, real-time illustrations. Thank you very much. So there are no questions so far. I'll just put up a couple of points for discussion, sir. So one is the swings in the central venous pressure waveform, with inspiration. And we often try to assess for fluid responsiveness. So the swing is obviously due to the pressure difference between inspiration and expiration that is being deflected in the right atrium. So if you have a lot of swings going on, right, going up and down, can that be taken as a surrogate for fluid responsiveness? Of course, considering the fact that it will vary with the depth of inspiration.
Yes. So that's the key point. So most of the data with respiratory variation in pressure waveforms is related to the arterial tracings, right? So when you have systolic pressure variations in the arterial waveform, it is there are three different. The differential is three things, right? You're hypovolemic, you're in tamponade, or you have severe RV dysfunction. Any of these three things can give you systolic pressure variations on your arterial tracing. Now, pressure variations with quiet respiration in the CVP and the PA wedge tracing have been correlated. There's a very smart physiologist in Canada called Sheldon Magda, and he's published on this. But the key is quiet respiration. The problem is a lot of our ICU patients are breathing hard. And in those cases, the swings in pleural pressures are driven by respiratory effort, and then you can't say anything about volume. The one thing to remember with these respiratory swings is, and this is particularly relevant in patients with poor cardiac function, a negative spontaneous breathing is a stress for the LV, right? Because when you take a negative pressure breath, you are increasing LV outflow. Positive pressure reduces LV outflow. So when a patient is, say, they're in LV failure and they're breathing hard, they're getting tachypnic because they're developing pulmonary edema, they will actually exacerbate the process of pulmonary edema. You can breathe yourself into pulmonary edema just by having these massive swings in your pleural pressure, which are going to stress your a weak LV. If you've got a normal LV, it's not a big deal. But if you've got a weak LV, you can give yourself pulmonary edema just by breathing hard. So, long answer to your question, but the short answer is, with quiet breathing, changes in CVP or the wedge pressure with respiration may be a marker for volume responsiveness. The other nuance to keep in mind is where your PA catheter is placed. If it is in zone 2, so West zones 1, 2, 3, sometimes you'll see that the CVP doesn't vary with respiration, whereas the PA catheter tracing varies a lot with respiration. That generally means that the PA catheter is sitting in West zone 2, where it's more affected by the alveolar pressures. So yes, it can mean volume responsiveness, but you have to be careful.
Thank you, sir. So then about the transmission of PEEP and alveolar pressure to CVP.
Yes.
Want to comment on that? How do we correlate or anything?
Yes. This is bad news, because the traditional teaching is that your CVP, subtract half the PEEP from your CVP, right? So say you've got a PEEP of 13 centimeters of water. I'm just going to make that easy for millimeter mercury conversion. 13 centimeter water is 10 millimeters of mercury. So if you've got a PEEP of 13 centimeters of water and your CVP is 12, subtract half of that, 5 millimeters. So your actual CVP is 7. The assumption underlying that is that the compliances of the lung and the chest wall are the same. They're equal, rather. That is almost never true. So I've done a fair amount of work in recruitment of patients with ARDS and acute respiratory failure, and the effect of recruitment on the right heart. And if your pleural pressures or your chest wall compliance is they're very different, right? So if say you're very obese, so you've got very low chest wall compliance, a lot less of that PEEP is going to be transmitted to your CVP. The corollary for that is that these patients tolerate recruitment really well. The other end of the spectrum, patients with severe emphysema, they may actually have a greater impact of PEEP on their CVP and also tolerate changes in positive pressure much less because their lungs are hypercompliant. So there is no one rule, sort of one size fits all. You definitely cannot assume that 50% of your PEEP is applied to this or is influencing the CVP. It depends very, very much on the chest wall compliance. One of the best ways to see that is you recruit patients. When you recruit patients, you look at the effect of your recruitment maneuver on the CVP. We've gone up to PEEPs of 35, and the CVP has gone from 12 to 15. We've gone from like a PEEP of 10 to PEEP of 35, and the CVP changes hardly at all in some patients. So there is no fixed ratio. It depends on the ratio of the compliances of the lung and the chest wall, if that makes sense.
Great, sir. Thank you. Finally, just a question about RV dysfunction or TR, right? So when there is RV dysfunction or TR, CVP can be really high, yet be volume responsive. You talked about volume responsiveness, and even at high values, it can be volume responsiveness. responsive, and the setting is generally RV dysfunction or TR. So you want to comment anything on that, sir? Because in India, in our ICUs, especially medical ICUs, we still use CVP for guiding fluids and their management.
I'm glad. So the traditional teaching for RV failure. So RV failure is also interest of mine. RV physiology and RV failure. The traditional teaching is that you start with a volume challenge, right? You have to be really careful if the CVPs are high, because it's actually more recent studies have shown that patients with high CVPs are not only are you not helping them, you are worsening diastolic ventricular interdependence, worsening LV filling, and worsening overall perfusion. The best way actually to decide whether or not to give fluid in patients with acute RV dysfunction is to put a probe on. I do a lot of echo. If you've got diastolic flattening of your septum, don't give that patient fluid, right? If your CVP is high, and especially this is acute RV failure, be very, very, very cautious about giving fluid, because the problem with RV failure, acute RV failure in particular, is not so much that it's just the RV stroke volume that's reduced. It's the septal shift that reduces LV diastolic volume and makes the LV very underloaded, right, underfilled. And the more volume you give to somebody who's already got a high right-sided filling pressure, the more likely you are to do that. And again, the arterial tracing in a patient with RV failure and a CVP of 15 is very likely to show systolic pressure variation. And that's because RV failure also exacerbates cardiopulmonary interactions, and in part because of interventricular interdependence, right? The exact same mechanism as pericardial tamponade. And you will see a systolic pressure variation or pulse pressure variation. The difference is with pericardial tamponade, giving fluids is a useful supportive measure until you get the pericardium evacuated. In RV failure, you're going to make things worse.
Great, sir. Thank you so much, sir. I think that is about all. It was wonderful listening to you and all the questions that you answered so nicely. And we are a lovely audience. And there's a question about whether this will be going up on our YouTube. Yes, sir. This will be going up on the YouTube in a couple of weeks. We'll be sharing it on YouTube, so you can review it again. And so many others who have not joined will be able to watch. Thank you, sir. Thank you very much. Good night. And thank you
for joining in. Thank you very much for having me. It's been a pleasure.